good afternoon, good evening, or good morning, if it is still morning where you are. You're lucky because you have the rest of the day and some more time to network on at the HITLAB symposium. Oh, no, sorry, HITLAB summit, I should say. So wonderful to have everyone coming in and listening to this wonderful conversation that these two ladies are going to bring to the summit. I have Rachel Sherrill, co-founder of Spark Solutions for Growth, as well as many other things. You have Rachel, as well as a HITLAB fellow. She'll be conducting this fireside chat with Summer Baburek. I hope I said that correctly, Summer. Chief Executive Officer of Hera Biotech, a wonderful femtech startup that I think is going to make some big waves. And you guys are going to be talking about algorithms and diagnosis, even breakthroughs in women's health tech. So Rachel, over to you, and looking forward to hearing what you guys have to discuss.
Well, thank you so much. It's great to be here, and I always love talking about important areas in women's health with amazing leaders. So Summer, it's great to have you. The focus of the conversation is really, the title is From Algorithms to Diagnosis, Breakthroughs in Women's Health. And just to level set, before we get into the content, what's really so important here is how much progress has been made in the space. I'm sure many people on this call have heard that this space, sexual and reproductive health, has raised $1.1 billion, maybe even a little more. That was through September in this calendar year. So that is exponential growth, not just geometric. We have more founders, we have more companies, we have more inventors, we have more investors, we have lots more people talking about this very important topic. And it all starts with solving important problems that currently don't have great solutions. They might have no solutions and they might have subpar solutions. So that leads me to Summer to talk about really the transformational solution that you have for an enormous problem that most people don't have any sense of how big it is. So could you share a little bit about Hera Biotech, the genesis for the solution and the biomarker and the approach, and what you're replacing? And I know that's a lot of questions at once, but just starting with what the company was designed to do and why this is so different, and at least from my perspective, so much better than the current option.
Sure, absolutely. So first, thank you for having me. I'm so excited to be having this conversation because, as you said, it's an exciting time to be alive in women's health and femtech, and just even in the very short period of time that you're talking about over the course of a year. I mean, when we first started pitching, we got the, a lot, when we said the word endometriosis. And now I've noticed in recent pitches, everyone's like, oh, yep, know what you're talking about. Got it. I'm like, wow, great. Over the course of a year, everybody's on board. That's amazing. So essentially what Hera is doing is, I like to go backwards to go forward. So I think one of the things that makes us so unique is our co-inventors who come from very different backgrounds. And I think it was that combination of very different backgrounds, very different perspectives that made our technology possible. So one of our inventors comes from a background in structural biology. He actually discovered the first of the genes that our gene set is heavily based on, which is connexins. He then sequenced the second one and has subsequently spent about 40 years researching the implications of this gene set. And the other inventor comes from a background in female reproductive oncology. And he's always had a passion for endometriosis because of its similarities to oncology. And they actually came together at an oncology conference. And where connexins struggle a bit in helping with oncology is that they don't have anything to do with unregulated growth of cells, right? Well, that's a perfect fit for endometriosis. So Dr. Kirma approached Dr. Nicholson afterwards and said, has anyone looked at this in endometriosis? And they looked at the literature and no, nobody had. And so on comes Hera, right? So then they invented the technology. I licensed the technology from UT Health, founded the company, and we completed a pilot study in 20 patients where we looked at this and compared it to the current standard, which is a surgery. So unfortunately, endometriosis is only diagnosable definitively through a surgical procedure performed under general anesthesia and it fails about 50% of the time.
And I've heard you use the expression to describe this surgery. It's a little bit of Where's Waldo, or finding a needle in a haystack in order to diagnose it even with surgery.
Exactly.
Surgery.
Exactly. And it's not a knock on the doctor. We've given them almost an impossible task. It's, hey, endometriosis can look like any of these things, and it can be anywhere from here to there. Go find it. So, I think it's, while that is a big failure rate, it's not a reflection on the skill of the surgeon. It's really just that we don't understand the disease. We haven't figured out a robust way to diagnose it without going and physically seeing it. And then going and physically seeing it becomes an almost impossible task. So that's where we are. And so to give you just a brief of our test. So our test is based on a sample of tissue from inside the uterus. So the tissue that's actually responsible for going out there and causing these lesions. So we're taking diagnostic capability out of the operating room, putting it into the doctor's office so a woman could go in for a doctor's visit instead of a surgery.
One of the things that's so interesting, and I know we're supposed to be talking about algorithms, and we will get there, and there's so much science upon which your solution is built. But when you look at the numbers, and the number of people who suffer from endometriosis, I'd love you to give some parameters around that. But also, what so few people understand who aren't in the space is what happens if endometriosis is not diagnosed, or is not diagnosed properly, or is not diagnosed in time. And I've heard estimates that it could take an average 7 to 10 years to diagnose it, which has huge impacts on fertility. So just like so many other areas in women's health, you can't talk about the hip bone's collected to the arm bone. You can't look at one thing and come up with solution, because we are so interconnected in our physiological, psychological systems. If you're dealing with endometriosis, it has physical implications. It has long-term health implications. It has reproductive implications. It has emotional implications. So this is not just when people say any of these things in women's health are a niche. Well, first of all, there are millions of people who suffer from it. And oh, by the way, the things they suffer from make it even bigger.
Right. That's exactly right. So there are no solid statistics on endometriosis because it is so hard to diagnose. So in the US, so one of what people consider a very developed, healthcare system, it takes on average 8 years, 10 plus doctor visits for a woman with endo to get diagnosed. And there's a lot of reasons for that, right? One of which is because what's the doctor going to do? Say, well, my option is to send you to a surgery that fails 50% of the time. That's not a great option. But the other part of it is the main symptoms of endometriosis are pain with period, pain with intercourse, heavy menstrual cycles. And what have we done? Well, that's normal. Welcome to womanhood. No, that's not acceptable. So, that's kind of where it is. So it's estimated that about 200 million women worldwide have endometriosis, which I think it's a funny statistic, especially since I'm from Texas, that if you put all those people together, that would be the 8th largest country in the world. That's not a small problem.
Talk about a visual. When we talk about, the size of the prize, and over 1 billion women will be in menopause by 2025. And in this space, we have to continually be shouting from the rooftops about those numbers. And that is such an unbelievable way to visualize how huge this impact is.
Right. And as you said, it's more than just the actual endometriosis lesion that's a problem. It's more than just the fact that this woman is in pain that's the problem. There's all of this domino effect that happens, the mental component, the emotional component, the reproductive component. And so what our solution is right now, our first step into the field is diagnosis, but that's just the first domino. Then we've got to understand it. We've got to track progression. We've got to figure out if we can change the outcomes and what are the predictive factors of those outcomes. And that's really where it comes back to what we're talking about today, which is algorithms and basically data and analytics, which is what my master's is in. So I could nerd out on that anytime.
So I love that. So going back to that, when you look at the statistics, we've said it a few times in this conversation, 50% of the diagnostic surgeries fail. What rates are you looking at? One, and number two, how much sooner, if the average is 8 years and 10 doctor visits, what have you identified is your path to diagnosis, and what have you proven so far?
Sure. So I like to start with the end, my end goal, my vision board, because I want to just keep pushing it out there into the
No,
universe.
Oprah. We didn't talk
Yeah.
about them.
So, for me, I truly believe that when a young woman first goes to her OB-GYN and has her first pap smear, our test should be there for her. Because if she does have endometriosis, this is the point in her life where we need to start making changes. Because now we're talking about hormonal shifts, we're talking about menstrual cycles, and we're talking about estrogen and all of the things that contribute to endometriosis. Endo is an estrogen hungry disease, okay? So she shouldn't go on about 90% of the birth controls that are available to her because it's gonna make the condition worse. And so it changes her care path through the entire healthcare system. And so that's where I would love for it to be. So today, it's going to be changing the way that doctors view these patients. There are a great number of doctors who are out there who are aware of this condition, who want to know, who are trying everything that they can, sans sending someone to a surgery that doesn't have great odds, right? But I think that where we will fall into the care path is when a woman comes in complaining of, issues with her menstrual cycle, easiest thing to do is put her on birth control. If she has endo, she's probably going to fail the first birth control. It's going to make her symptoms worse, or she's going to say, I'm still having these really painful periods. So we'll fail a second one, maybe even a third one. Then I think probably naturally the physician's going to do a vaginal ultrasound just to make sure we don't have something structural happening there. And if not, I think that's where our test should come in. That's where we belong in the care path. I think we belong earlier, but I'm going to have to make the argument for there now, and then we'll improve as we move forward.
One of the things that's so interesting when you talk about the care path is so many new solutions in women's health, again, are not a replacement. They're a new kind of behavior. So you're asking doctors not to do something different. They're still doing an exam, but you're asking them to include a step. They do the pap smear, they do the breast exam, they take the medical history. This is something that will have to become standard practice. And when you look at the algorithms and the predictive analytics and this idea that, I don't know what your ideal number is, you diagnose it within a year or within 2 doctor visits. So any detail you have on that would be really interesting. What is the end goal? Because so many people with endometriosis suffer unnecessarily, and it impacts, as we discussed, so many other areas of their life. So diagnosis is just the first piece. What is the health outcome that you as a company are working towards, and how are you using data to help you get there?
Sure. So I think the first thing, and quite frankly, it's probably not data related, is just giving you a name. Giving you a name to explain what's happening to you. I think that empowers women so much because it takes a feeling that you're having, an emotion that you're having, and it provides a reality to it. And so you can say, yes, I'm having these problems because of X now. And I think women are so great at this. They go, okay, now I know I have this problem. Now I'm going to do all of these things to fix or to improve what I'm doing. And so I think the first part is I would really love to be able to diagnose women within the first visit. If you're coming in and you're having severe menstrual pain, if you're having, heavy periods, pain with intercourse, some of these symptoms, give her our test and I'll give you an answer in a week. No different than a pap smear. So I would love that. I think realistically, we're probably talking about 4 visits instead of 10. Because I think the doctor's going to follow those first really easy things to do that are not invasive, so to speak. We are not non-trivial. We are an endometrial biopsy, so I don't want to take that component out of it, although we have some ideas. So give us a minute. But so that's where we are there. But in terms of the data, so what our test is based on is if you look at the lining of the endometrium, there's 2 main cell types, right? And these cell types, what we've discovered in our pilot study that we've done is they have almost perfectly negatively correlated expression patterns. So where the expression of our gene set goes up in one set, it goes down in another set. And so when you look at them together, they balance each other out and it looks like nothing is happening. It isn't until you separate those cell types and analyze them individually that you see this marked difference in these expression patterns. And not only does it just, tip its hat to women's health problems are complicated, but it also tips its hat to the fact that, okay, this is one of the reasons why we haven't seen this yet. It's taken until now till we've gotten these technologies to a point where we can really utilize them in a way to solve complex problems.
And I think that's such an important point. It's not like people are sitting around saying, well, this is too, we're not going to bother solving this. These are hard things to solve. Even just the thing you described. And again, I love how you speak and you can get a visual image in your head. We're looking at the same thing. We're just looking at them separate. If someone had thought of that before or could measure it before, of course they would have tried or wanted to try to do it. So it isn't for lack of interest. And we can get into how much women's health research investment has lagged. But for the purposes of this conversation, there's always been a desire to solve these. And sometimes it takes science to catch up. Sometimes it takes data to catch up. And sometimes it takes really visionary founders and leaders to catch up. So
absolutely.
Going back to that, so they do the biopsy, let's say it's in the first 4 visits. That could be depending on how much pain or discomfort or disruption this condition is causing. And then what? When you treat endo early, what happens that doesn't currently happen, or what good happens, or what bad do you avoid that you can't avoid if you have to wait 8 years on average and 10 different doctor visits to get to a diagnosis? What will we see less or more of?
Sure. So A, we're going to get her on an appropriate birth control pill that's not going to make the condition worse. B, we're seeing some really good clinical data, finally, where we're seeing a huge improvement in pain levels of patients if we do physical therapy, so a pelvic health specialist intervention. Then it also helps the patient to not get some of these adhesions of the pelvic muscles that happen from that intense, hunched pain, tightening, pushing on the pelvic muscles. So with this physical therapy, women have significant improvements. We're also seeing really great information coming out about these women going on non-inflammatory diets. So again, like you said, it's a whole approach. It's not a silver bullet, but knowing early prevents the adhesions. It prevents you going on medication that are inappropriate or could make your condition worse. It prevents you from having all of this mental angst over everyone's telling me I'm crazy, everyone's telling me I'm normal, and I'm not. I don't feel normal. So it's that domino effect. It's affecting each touch point of that patient through the system and putting her on a care path, a diet, a physical therapy regimen that will improve those things. It also gives you a lot of information about your reproductive health. If you do have endo, you have an idea you're probably going to struggle with fertility. And there are things that we can do to improve that. We can make adjustments in our plan. We can have our eggs harvested, or we can try to conceive early, or we can know that we need to see a fertility specialist early on, and they need to know that we have endo, because that changes your fertility interventions as well.
It's just amazing. It's just the very tip of the iceberg. And, again, peeling the layers of the onion to get to all the different pieces. What are some of the measures that might not exist today that you will have the data to comment on or to draw conclusions on? Will there be a way to more effectively get to a real number or a percentage of the incidence of endo? Will we be able to get to better correlations of endo and pregnancy or vaginal delivery or need for IVF or
all the things.
Result that, fill in the blank.
Sure. So to put it, broadly speaking, one of the things that is not done now, because it would be impossible, you'd have to have surgery numerous times, is to track the progression of the disease. We don't have a good understanding of how this disease progresses in women. So with this relatively minimally invasive procedure, or coming soon, maybe non-invasive procedures, we can analyze these expression levels. We know in the patients that we looked at that early stage endo, those expression levels are at one threshold. And at late stage endo, they're at a completely different threshold. And so with more data points, so just to give you a perspective, in our test, when we look at those two different cell types, we're doing single cell microfluidic analysis. It gives us about 2250 data points on each cell type. It's about 4,600 data points per patient. So it would be a statistical anomaly to have a false positive when you have that much data on two different cell types and they have to be opposite in order to make it work, right? So what we're really interested in doing is we're using cell clustering algorithms coupled with machine learning to process this massive amount of data. When we get 4,600 data points on even relatively small numbers of women, there's interesting inferences that can be made. But with a commercialized test where you're continuing to collect that data, you get to that point where you can look at predictive analytics. You have the data sufficient to perform that kind of analysis and look at, okay, does symptomology inform progression speed? Does, all the questions, you can, have tons of queries that you would have the data to support an answer for. And that's what's really, really exciting is, can we track drug efficacy through the clinic? That's not something that's done. All the therapeutics right now are aimed at symptom control, not therapeutic, control. And so that's where I get really excited to think about how we could improve outcomes in these patients based on understanding the progression of the disease.
It's so exciting to think about. Will there also be, or is this pie in the sky, or maybe Parabiotech 6.0, to get to patterns that could indicate who's predisposed to endo, whether it's by BMI or background or diet, or will there be a way to say when you have these factors, you are more likely to develop endo, so you might want to intervene here? Or is that too far away?
As a passionate data scientist with enough data points, I can answer any question.
You can get me to the moon. Okay.
Yeah. So, once we get, so obviously our target, so endo is most commonly diagnosed for women in their 30s. And I lovingly joke that as a late 30s woman, I say that's when we get real tired of accepting just mediocrity. We just go, nope, that's not it.
I'm not crazy.
Right. But I think that, if we can move this diagnostic into earlier and younger patients, even maybe menstrual patients, we may be able to detect that. Maybe there's a small shift very early that happens where we see that this tissue is predisposed to that invasive behavior as opposed to just geared for it. And we could see that with enough data, right? So this is going to be a lifelong thing that we go after. But to me, I'm just so passionate about it. And finally having the tools at our disposal that we're able to even dream about having those answers, because we're able to quantitatively measure these things now.
It's pretty amazing, because when we started, you were talking about, does she have it? Doesn't she have it? Now, with the things that you talked about and the 4,600 pieces of data or points of light that you have on every individual, there's so much more. We didn't even have the ability to ask the question, how is it progressing, before, because there was no measure. And that's one of the things that's so exciting in women's health, is really, and scientific discovery in general, is really just pioneering new ways. When we see all these companies in women's health, you will, I imagine, have the largest database of endometrial tissue or statistical points about it. And now we hear all these period tracking apps have more information on menstrual flow, and the fertility companies have all this information about fertility. And with the machine learning and with the algorithms, we are getting, in spaces where we're further along, we are getting to being able to predict, or at least have a signal that there might be a problem or there might not be a problem. So when I think about some of your endpoints, like fewer women in the world in pain would be a great improvement for the world on so many different dimensions.
Absolutely. I mean, and the thing about it is, I always equate this when I'm talking to my dad, who's 87, who wants me to explain things to him, I say things like, it's what we're doing is like what the pap smear did for cervical cancer. we knew it was bad. We knew it was killing people, but we didn't really know what was causing it. Along comes the pap smear. We figure out that these very small changes on the surface of the cervix are what predict, this is happening. Then we figured out it's the HPV virus. Now we have a vaccine. I mean, it was the Pandora's box for cervical cancer. And I think that we're just, in terms of women's health broadly, we're just at the tip of the iceberg, and it's going to be so exciting to see what we are able to learn and the problems that we're able to solve. But for 51% of the population, I mean, that's a huge contributing factor if we can alleviate some of these burdens from them.
Well, that's a great place to stop, I think, with this idea of alleviating burdens. And the work you're doing is so exciting. And I love the example of the pap smear as where we started and where we got to. And to think that you're sort of at ground zero for making these same changes and transformations in endo is so exciting. So we'll be watching and cheering you on. And I know sufferers will be happy to learn about you. Certainly clinicians will be delighted to have another, quiver in their toolbox. So thank you so much. And we can't wait to see what we learn from you.
Thank you.
Wonderful discussion there, Rachel and Summer. I think we all definitely took away some really good key points. It doesn't have to stop there. I know we run out of time on the main stage, like I said before, but the networking rooms are open, and I've put aside a separate networking room for you and Summer and anybody else that wants to continue the conversation offline, so to speak. And we've got a post panel from algorithms to diagnosis breakthroughs in women's health tech and networking room in the networking room. So please feel free to gravitate over there. It's an honor again having you both on, and hopefully you get more out of the summit as the days progress. So thank you very much, guys, and I will catch you at the summit.